Okay, there we go. So, good evening, all. Welcome to those of you who are new for the first time with me in a webinar, and good evening to everyone who has been with me before. So, as you guys know, before I like to get started, I like to know where everyone is from. So, those of you who've been with me before, you guys know. I always start out, where's everybody from? I am here in
Virginia in the house.
Okay, but as usual, Miss Juliet, as usual. There she is. It's not a webinar without Juliet. Pittsburgh, St. Louis. Hello. Who else? Miami. Hi, Miss Crespo. You are here with me. So you already know the rain that we've been getting. It was bad. Monday was real bad. I couldn't even get to work because we got flooded. Ghana, California, Virginia, Boston, Detroit. Hello, hello, Jersey. Okay, a couple of East Coast people. Cali. So you about what, 3 hours behind us? Okay, so it still should be light there. Haiti, hello, Nairobi. I see some familiar people here. I think I have some regulars. That's awesome. So, hello, hello, North Carolina, hello. So tonight, as you guys can see, it's raining. Listen, Miami weather is very, what's the word? Bipolar. We cover bipolarism in the mental health webinar. 1 minute the rain is coming down. You would think it's hurricane season going on, and then give it an hour or so, the sun is out like nothing happened. Texas. Okay, hello, Texas and Indianapolis. Okay, we got a good little mix up in here tonight. Awesome. So tonight, as you guys can see, we are covering hypothyroidism, and then of course some subcategories, causes, main causes, Hashimoto thyroiditis, Graves disease. So we got some good information for you guys tonight. So the way that I structured tonight's webinar, I structured it the way that I learned it when I was in school. Your favorite topic? Okay, so I hope I do it some justice. Okay, you gonna let me know at the end, did I do it justice since it's your favorite topic? So I structured the webinar the way that I learned it. The good thing about hypo and hyperthyroidism is that they're literally the opposites of each other, if you can picture that. It's like what you see in one, you're going to see the opposite in the other. What you do to treat one, you're going to kind of sort of do the opposite in the other. So that is what helped me to learn hypo and hyperthyroidism, just thinking about it in those terms. So that is exactly how I structured this webinar. Normally, I'll stick to one content area, go through all of that, break, and then go to the next content area. But what I kind of did with hypo and hyperthyroidism, I kind of intertwined them throughout this whole presentations. And again, that's how I learned it. So hopefully it helps you guys, review and learn the content a little bit easier. Okay, so and also for you guys who are with me for the first time, I like students to be very, very active. Okay. I like students to be engaged. Don't hesitate to unmute yourself and join in the conversation, add something. If you're not comfortable speaking, you can always type into the chat. I do look into the chat throughout the presentation just to catch any questions. If I do miss someone's question, don't hesitate to unmute and say, I asked the question, and then I'll go back into the chart and look. Hello, Cincinnati. So link, when you say link, John, I think John's been with me before. When you say link, John, what link are you referring to? Just want to make sure I understand. Did everyone see the PowerPoint that was uploaded? You can type into the chat, yes or no. I want to make sure you guys have that. Yes? Okay, perfect. Thank you. So, John, what link are you referring to? Inviting. No, Anne Marie. So I did upload the PowerPoint beforehand. So I'm not sure how you guys see the view. Oh, there we go. Thank you, Shy. As far as the PowerPoint, I'm not sure how you guys is set up on your end. On my end, I just uploaded and it says this is uploaded. Can anyone want to chime in and tell the students, afterwards how to find the PowerPoint so they can download it and save it? It should be when you click on the webinar, you should see uploaded.
Yes. On the previous webinar, if you go in it, you will see it. You can just click on it, and there is a link there. You can just upload it.
Perfect. Thank you, Juliet, always to the rescue. You should come every webinar I do, Juliet. Okay, just be right there. Just right there. Okay, so it looks like you guys have the links, like you have the password. So let's go ahead and get started. Okay, so these are our objectives for tonight's webinar. Okay, basically, it's just learning about hypothyroidism. This is a review, talking about, risk factors, manifestations, treatments, diagnosis, nursing management, because there are some very specific things that we as nurses are expected to do when we have clients with either hypo or hyperthyroidism. And you guys know how I like to do it. I always refer to the NCLEX, things that you could see, So of course, as we finish tonight's webinar, we do have our NCLEX review questions afterwards. So first up, hypothyroidism versus hyperthyroidism. So first things first, what is hypo versus hyperthyroidism? So hypothyroidism is very, very simple. If you wanted to break the words down, and that's something that I'm a big component of, learning how to break words down. That is going to help you guys on the NCLEX a lot. Yes, there it is. High versus low. Hypo, okay, low, under, submerged, submissive, anything that's low. Hypothyroidism, and of course, you guys know the word thyroid. So, under functioning of the thyroid. Okay, underactive thyroid, underperforming thyroid, low stimulated hormone, thyroid. That's all of that stuff fits into one category. Okay, and because you have an underactive thyroid, you're going to have low hormones related to the thyroid gland. Okay, now the most common cause of hypothyroidism is Hashimoto's thyroiditis. And I do have a little slide that does kind of, point to that. Iodine of deficiency can cause hypothyroidism, but you don't see that as often. So one of the main causes of hypothyroidism is Hashimoto's thyroiditis. Okay. And then on the flip side, you have hyperthyroidism and overactive. Hyper means overactive, overstimulated. So an overactive thyroid is what you have when you have hyperthyroidism. So in this case, you have very high levels of thyroid hormone. So here's the issue. You have to find a balance. You have to find an equilibrium between your two hormones. Because if you have too little of the thyroid hormones, you're going to see complications of that. If you have too high of thyroid hormones, you're going to see the complications and the side effects of that. So your body has to find a balance. And when there's a disruption in that balance, depend on where the disruption is, you're going to have underactive versus an overactive thyroid. Okay. Most common cause for hyperthyroidism is Graves' disease, which I have included a little slide about that as well. Other things that can cause an overactive thyroid, you could have growths, tumors that can cause an overreaction type response, but the most common cause would be Graves' disease. Inflammation can also indirectly cause your thyroid to become a little bit overactive, but again, Graves' disease is the most common cause for hyperthyroidism, and I do have a little slide for that as well. So let's talk about causes. First, hypothyroidism. So hypothyroidism develops when the thyroid gland does not produce enough thyroid hormones. Okay. So we already established underactive thyroid. So the causes typically are autoimmune diseases. So if you guys know generally what an autoimmune disease is, pretty much when the body attacks itself. That's one of the best ways to describe autoimmune disorders. And honestly, we have no idea why the body all of a sudden just wakes up one day and says, you know what, I'm going to attack myself. I'm going to, no longer recognize my body as my own. So conditions such as lupus, arthritis, okay, those are all autoimmune disorders. And again, we have no idea why all of a sudden a person wakes up and the body is attacking itself. Okay, the most common cause for hypothyroidism is Hashimoto's thyroiditis, or you may see the term Hashimoto's disease. They're kind of sort of the same thing, just interchangeable. And that is an autoimmune disorder in itself. Okay, so basically, your immune system is all of a sudden going to start attacking the thyroid out of nowhere with Hashimoto's thyroiditis. Then you have age and gender. Okay, women are more likely to develop hypothyroidism, and this is scientifically proven. Now, here's a thing that a lot of women don't think about. Being that I am a women's practitioner, sometimes whenever I have a client that has issues with losing weight, Okay, because you can diet, you can exercise, you're doing everything right. You're drinking more water, less sugary carbs drinks, you eat more salads, cutting back on the gluten, like you're doing everything you're supposed to do, getting your walks in, but for some reason you are not losing weight. You could be even gaining weight. And it's like, you're not taking no medication that causes weight gain. You don't have no fluid retention. It's like all of that is normal. So, what could possibly be the reason why a woman has so much trouble losing weight? We're going to start looking at your hormones. Okay, that's the next logical thing to look at. And one of the most important hormones that people don't think about is the thyroid. Okay, we're gonna look at your thyroid levels. Depending on the thyroid levels, that could be a reason why a woman is having so much trouble losing weight, despite the working out, despite the eating healthy, and all the good lifestyle practicing habits. So a lot of times you could be doing everything right and still having trouble gaining weight. I mean, losing weight, and you're gaining weight without even trying, and you're doing everything right. The thing a lot of people don't think about, what's going on with the thyroid? Okay, could you possibly have an underactive thyroid? Okay. Typically, when we do see thyroid issues, it usually is people over the age of 60. Now, yes, you can be a little bit younger than that and start having hypothyroidism signs and symptoms, because again, it could be due to, an inflammation, getting autoimmune. Okay. You could have had an injury to the thyroid and it affected the way it is functioning. So it's not just age, being that we see thyroid issues, but it's more likely seen in older individuals. Pituitary gland issues. So your pituitary gland is the main supporter and supplier for the thyroid gland. The pituitary gland controls the thyroid. So the pituitary gland is the controller. As a matter of fact, the pituitary gland controls a lot of your structures when it comes to hormone production. Okay, so if there's something going on with the pituitary gland, then it is going to not stimulate the thyroid glands like it is supposed to. And then postpartum, that is another hidden culprit. Women who just had babies, you may start to see issues with your thyroid gland. And that's a lot of things we don't think about as women after we have kids. Again, we're having trouble losing weight. We have these strange feelings, and it's our thyroid, and we're not even thinking about it being our thyroid. That is why when you have a postpartum checkup, you need to be very honest with your provider. What are you feeling? Because it's been 6 weeks since you've been in the hospital, because that's about the average time you schedule your postpartum checkup. And we want to know how you've been feeling, how's your recovery. And you need to let the doctor know, women, after you have babies, if you're having these feelings, signs, and symptoms for hypothyroidism, which we will talk about. Next up, let's talk about causes of hyperthyroidism. So, hyperthyroidism is a condition where the thyroid gland produces too much of thyroid stimulating hormones. So causes for that could be number one, Graves' disease, another autoimmune disorder where the immune system mistakenly attacks the thyroid gland, but in this cause, it is going to make the thyroid gland overstimulated. Okay. See, with Hashimoto's thyroiditis, it is going to suppress when it attacks the thyroid gland. So it's going to make the thyroid gland underproduce. With Graves' disease, it is a stimulating autoimmune attack. So now your thyroid gland is going to go into overdrive. It's going to kick up a notch. Okay. Thyroiditis, inflammation of the thyroid gland. So this could be triggered by infections. It could be triggered by autoimmune response. Okay. Now with this attack, you're going to have the thyroid gland leaking excessive hormones. So it's not like the thyroid gland is even trying. It is just automatically leaking all of this extra thyroid stimulating hormones into your bloodstream, which is going to overly, okay, cause the signs and symptoms that you typically see. Then you can have something called toxic thyroid nodules. Okay. So when we say tumors, a lot of times people hear the word tumor and they always think cancer. That is not always the case. You can have a tumor, you can have a growth, okay, and it is non-cancerous, it is non-malignant. Now, of course, we need to biopsy it, we need to check it, but there's a lot of tumors, there's a lot of growths that are not cancerous. Okay, they are called benign growths, benign tumors. So, toxic thyroid nodules, even though the word toxic is there, don't get fooled by that. It is called toxic because of the effect that it has on the thyroid gland, not because it is cancerous or malignant. Okay, so the toxic thyroid nodules, non-cancerous growth within the thyroid gland itself, and it becomes overactive. So these nodules, these growths, these benign growths, okay, are growing inside of the thyroid gland, and those growths are going to overstimulate the thyroid gland itself. Iodine excess, that is another hidden culprit for hyperthyroidism. If you just happen to ingest a lot of iodine, okay, and it can be from different sources. You can have a diet and not realizing you just eating a lot of, or you're ingesting a lot of iodine. And that's something that people don't think of. We talk about controlling diet, we think of things like salt, sodium, carbs because of diabetes, stuff like that, low calorie to lose weight. How many people really say, you know what, I need to make sure I don't overdo it on the iodine? Okay, that's another thing, especially people who have issues with body system. It could be the thyroid, the hidden culprit. So you also have to consider how much iodine you are consuming in the diet. Medications can also expose you to a lot. Is it the same dye we use for the scan? It is. Iodine is iodine. Yes, ma'am. I'm sorry, John. Yes, sir. Iodine is iodine. Okay, all of it is the same thing. Now, if you have allergies, okay, then by default, you're not consuming a lot of iodine if you just have allergies to the fact. Okay. Lastly, pituitary tumors, again, growths, tumors. Not necessarily cancerous. It could be malignant. It could not be. But there's growths that can cause the pituitary gland to be overly stimulated. And then that will directly affect the stimulation of your thyroid gland. Okay. And when we say stimulation of the thyroid gland, we're talking about overproduction of something called thyroid stimulating hormone, which we will talk about. Okay. So the pituitary gland, when it stimulates the thyroid, okay, it is going to it is because of the production of thyroid stimulating hormone. So the pituitary gland releases thyroid stimulating hormone. That is what's going to now trigger the thyroid, and then you have the releasing of the thyroid hormones themselves. Okay, so let's talk about the roles of hormones. One of the ways that it's going to help you guys understand hypo versus hyperthyroidism is to understand the roles of the hormones themselves. Okay, so when we talk about treatment or we talk about diagnosing, either or, a lot of it is pent on thyroid hormones. What is there, what isn't there. So if you understand how the hormones work, then you understand, okay, if I have a client and I suspect hypothyroidism, what would I expect to see type thing. Okay, so produced by the pituitary gland, the primary function of thyroid stimulating hormone is to stimulate the thyroid gland to produce and release two types of hormones, okay? T3 and T4, okay? T4 converts into T3. That is how it's normally supposed to go. And T3 is what our body utilizes. Okay, now in order for you to have a regular balance of your thyroid hormones, you have to have a conversion of T4 into T3. Okay, if there is a disruption in that balance, you can have too much of T4 floating around. Okay, because for whatever reason, T4 does not convert into T3. Now you have hyperthyroidism. Now, unfortunately, if there's something going on with the pituitary gland itself or the thyroid gland, then you are not producing TSH, and then there is no stimulation of your thyroid gland. So then there's no conversion of T3 into T4. And again, you're going to see the symptoms from that, which we will talk about. So when it comes to hormones, okay, for hypothyroidism, when the thyroid hormone levels are low, the pituitary gland releases more thyroid stimulating hormone. So the drop in thyroid hormones in your body is a regulator for pituitary gland to get active. Okay, the pituitary gland says, oh, too little thyroid hormones, let me go ahead and release TSH. That is how that works. So now the pituitary gland has released TSH. Now that is going to go into your thyroid gland to produce T4, again to go into T3. Okay, now what if the thyroid gland does not respond to thyroid stimulating hormone? So that means the pituitary gland. Now, here's the thing, it's not like there's a direct communication line between all your body systems. Honestly, if it was that way, I think a lot of conditions wouldn't be as bad as they are. All your pituitary gland knows, I don't have a lot of thyroid hormones floating around. Let me release TSH. That's all the pituitary gland is doing. It has no idea what your thyroid gland has going on. It has no idea. There's no direct communication link. So here's your pituitary gland, right? Producing all this TSH. It's just producing it around the clock because it's reacting to your low thyroid hormones. Now, your pituitary gland has no idea that your thyroid gland is not responding to all of this TSH it is releasing. So now you just have a bunch of TSH just floating around in your body, not doing anything. Okay, now that's hypothyroidism. On the flip side, when you have hyperthyroidism, now your thyroid gland is just overreactive for whatever reason. It has nothing to do with TSH. As a matter of fact, your pituitary gland don't even have to produce anything. Because remember, the trigger for your pituitary gland is low thyroid hormones. So if you have an overactive thyroid, you do not need TSH to stimulate it. So if I'm talking about levels of TSH, and now keep in mind that is one of the main ways we diagnose thyroid issues. We look at the levels of TSH in your blood. So if you have abnormally high levels of TSH, that is a clinical sign for hypothyroidism. And then remember what I just said. When you have an overactive thyroid, it does not need stimulation by TSH. So your pituitary gland is not producing it. So on the flip side, you have very low levels of TSH, but you have high levels of the thyroid hormones, T3, T4, floating around. Okay, so that is how we kind of diagnose the thyroid issues. So I'm going to say it again. For hypothyroidism, you need TSH to stimulate your thyroid to release thyroid hormones. So low T3, low T4 levels is going to stimulate or trigger your pituitary gland. Pituitary gland releases TSH. That is what stimulates your thyroid hormone. When you have hypothyroidism, for whatever reason, your thyroid does not respond to the trigger TSH. So the pituitary gland is steady releasing TSH, but the thyroid gland is not responding. So if I was to look at the blood levels of that client, okay, I'm going to see high levels of TSH, low levels of T3, T4. That is hypothyroidism. On the flip side, there's not enough TSH because there doesn't need to be TSH. Your thyroid gland is stimulated regardless of TSH present or not. So I'm going to have low levels of TSH, but because I have an overly stimulated thyroid hormone gland, I'm going to have high levels of T3, T4. So hyperthyroidism, low levels of TSH, high levels of T3, T4. So when we do your serum labs to help diagnose, that is what we're looking for. Do we diagnose you as hypothyroidism, or will we diagnose you as hyperthyroidism? Okay. Now, typically, when it comes to hyperthyroidism, okay, it is very, very important that we catch this early because there is a really serious life-threatening complication that comes with an overactive thyroid. And we will talk about that in this presentation as well. So, signs and symptoms. So, I'm going to go through signs and symptoms and then we'll take our first little breather. Okay, so signs and symptoms, hypo versus hyperthyroidism. So this is what I was talking about. Another way that I was talking about when I mentioned, oh, somebody in the chat, let me see. T3, T4 is low. Okay, so low TSH, high. Okay, so if I'm understanding you, John, in hypo, you have, yeah, that is correct. In hypothyroidism, you have high TSH and low T3, T4. Yes, that is exactly right. Okay, and then it is the opposite in hyper. You have high, I'm sorry, you have high TSH, you have low T3, T4 hypo. So it's the opposite in hyper. You have, yeah, it's literally exact opposite. Literally opposite. So in hyper, you have low TSH, but high T3, high T4. So it is literally the opposite. Okay. So with your signs and symptoms, now a lot of these are literally the exact opposites. One of the most clinical signs for hypothyroidism, besides the inability to lose weight or weight gain, intolerance to cold. Okay. When we say intolerance to cold, it makes sense if you're in a very cold environment and you are cold. That's expected. If you're in, now Miami people is somebody in in a webinar from Miami. And if you like me, y'all know how Miami goes. We don't have winters. The rest of the world. Our winters, according to the rest of the world, is vacation weather. But to us people in Miami, listen, when it gets into the 50s, we got, boots, scarves, we got our stuff on because we cold, right? So that's normal. But if you're in 70-degree weather and you're freezing cold, that is abnormal. Now, usually one of the first things I ask a person, if they are cold, freezing, but they're not in a cold environment, what is your iron levels looking like? Because usually the first thing you think is anemia. Okay, a person who's anemic have intolerance to cold. They're cold when the air around them is not that cold to warrant that response. Another question I will ask, if your levels of iron are fine, what's going on with your thyroid? Uh-huh. Low and slow. That's a great way to remember it. Low and slow. Okay. That's what someone put in the chat how they remember hypothyroidism. So low intolerance to cold. They're always cold. They're always freezing. Okay. They gain weight very easily without even trying, or they have difficulty losing weight. Okay. They do not sweat a lot. Believe it or not, people with hypothyroidism do not sweat like you normally would expect a person to sweat. They're always constipated. Okay, so we're going to talk about diet as well. Okay, they may have depressed moods. They may be very irritable. So you might see some mood swings in a person that has hypothyroidism. For women, okay, an underactive thyroid can interfere with your menstrual cycle. So if you are a woman and you're having trouble getting pregnant naturally, okay, that is why one of the things we do is we first look at your hormones, because everybody thinks estrogen. Oh, if you don't have correct levels of estrogen, you're going to have trouble getting pregnant. It's not just estrogen, it's a lot of other hormones that play a role in your ability to get pregnant naturally. So we're also going to check your thyroid hormones as well. Your nails are very, very brittle. Brittle hair, brittle, dry hair, brittle nails. Your heart rate is very slow, so bradycardia, and the person may experience a lot of joint pain, muscle pain, joint pain. You might even mistaken it for arthritis. Remember, this is more seen in older people. Therefore, I might suspect you have arthritis. And I'm going to think, you know what? You're getting up in age. It's normal to start feeling some aches and, pains in your joints. But it's not arthritis. But again, being that the number one cause is an autoimmune, some of the labs will support autoimmune dysfunction. It's just up to the practitioner to now throw in the blood work and let's see what's going on with these hormones. Okay. Puffy face, also a culprit. Okay, so when we are nurses and we are monitoring these symptoms, that is what we're looking for. Because if you are treating hypothyroidism, I would expect these signs and symptoms to improve. That is how I know it is working effectively. Now, on the flip side, hyperthyroidism, one of the first things you notice, intolerance to heat. These people are always hot. It's like it's so hot in here. And of course, because they're so hot, they sweat a lot of sweating. We can even call it diaphoresis, extreme sweating. So they have intolerances to heat. So instead of being cold all the time, they're hot all the time. And it's not like they're in an environment where it is warm. Okay. They just have heat intolerances. Okay. Sweating a lot. They do not have trouble losing weight. As a matter of fact, they lose weight without even trying. Now, of course, somebody like me might be envious that you can eat, and you don't gain no weight. It could be a thyroid and you not even know it. Okay. The nails are very thick. Okay. you get a lot of nervousness, a lot of anxiety, a lot of like tremors and jitters, diarrhea. So on the flip side, it's not constipation, it's diarrhea. Then you may even have some muscle fatigue. Now, those are symptoms specific for hyperthyroidism. And then you have smack down in the middle. These are very general manifestations and they can go for either or. Feelings of tiredness, fatigue, insomnia, so having trouble sleeping, and hair loss. And again, that is why women are more affected than men. A lot of these things we look at in women. First thing, let's check your hormones. Okay. When you do have a menstrual cycle with hyperthyroidism, it is very light and short. Now, someone might think, oh, that's a great thing. But again, if it's accompanied by other signs and symptoms, then something is wrong. We need to look at your hormones again. Okay, so those are your signs and your symptoms of hypo versus hyperthyroidism. Okay, so let me see what time it is. It is 9:40, so we make a good time. Let's take our first breather. It is 9:40. We'll do 10 minutes. So we'll be back at 9:50 and then we will continue. Okay, so 9:50, you guys, for our first break, we will return. Okay, everyone, we are back. Let's pick up where we left off. So we just finished comparing our signs and our symptoms. So we have hypothyroidism symptoms versus hyperthyroidism symptoms, and then you have your symptoms straight down the middle, which can be seen in either disorder. So now let's talk about how we diagnose. So we kind of already went into this, but this is going to give us a little deeper insight as to how we officially diagnose thyroid related issues. So first things first, the doctor's going to do a medical history and a physical exam. So they're going to ask you some questions. Okay. Now keep in mind in the very, very beginning, there may be no idea that there is a thyroid issue. Okay, it could be very, very general symptoms. Remember, fatigue could be anything. Fatigue could be anything. You might see some nausea, you might see some vomiting. If a client tells me that they're having intolerance to cold, I might think your, iron levels are too low first. So we may not see the thyroid issues very, very in the beginning. So the symptoms could be vague. So the doctor may need to do a very extensive health history and exam, ask you questions, how long you've been feeling the way you've been feeling, and just ask you to describe what it is that you are feeling. Now, if you're having the classic symptoms of thyroid related issues, then maybe a diagnosis can come quicker than later, because of course you're giving insight into the classic signs and symptoms that we would expect to see. If it is hyperthyroidism, there may be a quicker diagnosis than thought. The doctor may actually do an assessment of your thyroid. They will typically stand behind you, and they would kind of put both hands in this area here, and they would just gently palpate and just feel the size of your thyroid. One of the manifestations of Graves' disease, which we will get into it, I also put pictures, is something called a goiter. Okay, a goiter. A goiter is a very enlarged thyroid. Okay, so it looks like a big swelling area right here on your neck. And the bigger the goiter, the bigger the swelling regarding the thyroid gland. So when they stand behind you and they press around your neck, they're just trying to feel if your thyroid gland is enlarged. There's also a manifestation that they will look for with hyperthyroidism, and that is the bulging eyes, ophthalmos. So we'll see that as well when we talk about Graves' disease. Okay. Blood tests. So of course we're gonna do some labs, of course, and the doctor's going to order a complete full panel, especially if they have no idea what's going on. So not only do we do, the CBCs, and we look for the electrolytes and iron and H and kidneys and liver labs, they're also going to probably do hormones, of course. Okay, especially if you describe symptoms like intolerance to cold, problems losing weight, mood swings. Okay, definitely they'll look into your blood work and your hormones. Then remember what we look for in terms of diagnosing. So the standard criteria for diagnosing hypo versus hyperthyroidism, they're going to look at your thyroid stimulating hormone levels, and they're going to look at your T3, T4 levels. So again, so there's no confusion. If a diagnosis of hypothyroidism is to be made, you have very high levels of TSH, thyroid stimulating hormones, and you have low levels of T3, T4. That is because your thyroid is not responding to the TSH that is being produced by your pituitary gland. So if I was to look at your blood work results again, high levels of TSH, low levels of T3, T4, hypothyroidism. On the flip side, if I was to look at your blood levels for hyperthyroidism, I would see very low levels of TSH and very high levels of T3, T4. That will be the definitive diagnoses for either or. Okay, they may do some imaging studies. We might just want to take a look at thyroid gland. Let's just see if we can get an idea of what's going on here. We may have already made a diagnosis, but they may want to just get some more structure imaging just to kind of see what exactly is going on, especially if it starts to enlarge. Okay, biopsies could be done in some cases. For example, they may do a biopsy on the pituitary gland if the pituitary gland is overly stimulated, or they may do a biopsy on the thyroid gland if the thyroid gland is overly stimulated. Remember, there could be growths on your thyroid. There could be growths on your pituitary gland. We need to biopsy it. Is it malignant? Is it not malignant? Meaning, is it benign? Either way, it could be stimulating or understimulating your hormone.
Professor, what about goiter in the hypothyroidism?
So there's not typically, so you typically will not see a goiter in hypo. Can you? Some cases I've heard they have seen goiters, but honestly, that is clinical. That's not a typical manifestation. So when you talk about, especially for the NCLEX, when they talk about recognizing signs and symptoms, they're not going to be talking about those signs and symptoms that you rarely see. They want to know about the clinical stuff. Like if I had to pick when would I see a goiter, it would always be hyperthyroidism. But have there been goiters in hypo? I have heard of those, but that's not very common at all. Not common. So
Okay.
I wouldn't count on seeing a goiter in hypothyroidism, but I would count seeing it in hyperthyroidism, especially with Graves' disease.
Okay.
Okay. And then clinical evaluation. Again, that's just combining, and again, that's now again, if they're not suspicious of your thyroid and they think it could be anything, this is the time to start ruling out stuff. Like, I think it could be this, so I'm going to look further into it. Okay, I get a diagnosis or a final prognosis. That's not what it is. So it got to be something else. So let's rule this out. Now let's look at this. And all of this is based on the results that come back for your labs and your biopsies and all of that good stuff. Okay. Now let's talk about treatment. Now we talk about NCLEX. Okay. NCLEX, if it's not recognizing signs and symptoms, it's about treatment. And a lot of times with treatment comes a lot of room for patient family education. Okay. So first things first, hypothyroidism. Now the treatment is pretty simple. It's not a lot here to know. There's really one thing that we do to treat hypothyroidism. You have to replenish what you don't have. Okay. You have to replenish or you have to provide your body with what you are not producing. And that is T4. Remember, you need T4 to turn into T3. Okay. The medication is called levothyroxine, also known as Synthroid. So, NCLEX question. A nurse is taking care of a client who has been recently diagnosed with hypothyroidism. What medication would the nurse expect to be ordered? Those are the types of questions you see on the NCLEX. Okay. Do you understand what's going on with your client and are you aware of what treatment should be done? Now, we don't diagnose, we don't write prescriptions, unless you are a practitioner with privileges. But as a typical RN, we don't diagnose, we don't write prescriptions. However, we know what's going on and we can at least anticipate what the doctor will order, or we can expect the doctor to order something. So if I have a client with hypothyroidism, right off the rip, I'm expecting a diagnosis of hypothyroidism to come with in order to start this client on levothyroxine, also known as Synthroid. Now, the education that comes with Synthroid is very, very, very important. This medication does have a low level or low room for error. This medication can be toxic. So there's a couple of things that clients need to know how to properly take this medication. First of all, it needs to be taken on an empty stomach. That's number one. This medication is best absorbed on an empty stomach. Okay. And you should take it in the morning. A client may ask, why do I have to take this medication in the morning? Sometimes you get questions like that on the NCLEX. Clients want to understand, why are they getting these instructions? So that means you, as the nurse, you need to know, why do we tell you to take it in the morning? Because one, levothyroxine can cause insomnia. Okay. So by the time it is nighttime, you want that to wear off. You want that insomniac effect to wear off. You want to be awake during the day. Okay. And you want to go to sleep at night. So take it in the morning because it can cause insomnia. So by the time it's time to go to bed, you don't have those issues going to sleep. Secondly, hormone stimulation and release is most active in the morning when you wake up. We want the levothyroxine, the synthetic T4, to stimulate. Okay, hormone production. We want your body to look at the levothyroxine as a normal part of the process of my pituitary gland stimulating everything. And I want this synthetic levothyroxine to kind of fall into place like everything else. So take it first thing in the morning. Okay, take it on an empty stomach. Now, levothyroxine does have a very bitter taste. Want to make sure the clients understand that it's not the best tasting medication. It's in fact very, very bitter. So, just be careful when you take it. It can cause some nausea and vomiting, but that's just typical because of the taste. Now, if you do tend to get a little bit of stomach irritation, which can happen, okay, you can mix it in a little bit of water. Okay, remember, it's best really on an empty stomach. Water doesn't really interfere, but if it's just easy for you to take it like that, mix it with some water and you can also take it that way. Because some people will experience a little bit of stomach irritation with levothyroxine. Now, there's other medications. Okay. Now, worst case scenario, the levothyroxine is not effective. There is synthetic T3 medication that you can take. However, a first line defense for treating hypothyroidism is levothyroxine. Okay. And then another very important piece of education that clients need to be told, this is lifelong. Okay. There is no cure for hypothyroidism. There is no, you only take the medications for 6 months and then you're out. No, this is lifelong. Okay. So the whole taking it first thing in the morning, taking it on an empty stomach, take it with a little bit of water if you have trouble taking it, getting your blood levels checked because you're also going to have to make sure the client understands you're going to have to come in regularly for us to check your blood levels with the levothyroxine because it can be toxic. This is for the rest of your life. This does not stop. Okay, so part of the issue, remember, when clients do not get well or they don't get better, remember, a big issue is non-compliance. They should not take it with other medication. Yes, someone mentioned in the chat, very good. Usually, yeah, they shouldn't. So if by chance they are prescribed other medications, you would tell them take the levothyroxine first thing in the morning, and then the other drugs will be taken a couple of hours after that. So they should not mix it with other meds. No, they should typically take it by itself. Okay. Now, hyperthyroidism. Now, remember, this is the opposite of hypo. So we do not need levothyroxine because the body is producing more than enough T4 when you have an overstimulated thyroid. So now the question becomes, how do I stop this? So that is the foundation for treating hyperthyroidism. What can I do to stop this thyroid gland from being so overly stimulated? Okay, one of the things that they can do, anti-thyroid medications. Okay, trapezole, or PTU, those are very common medications that block the overproducing or overstimulated thyroid gland. Okay, those are effective. Okay, if by chance those are not effective because everybody doesn't respond to medication the same way, you have another option when it comes to medication, radioactive iodine therapy. Okay, now when you take a dose of radioactive iodine, okay, typically it damages the thyroid cells. So this is risky. Okay, with this particular treatment, you definitely have to have your client sign informed consent. Okay, that's another part of nursing, knowing when an informed consent needs to be signed. Okay, and knowing your responsibilities when it comes to informed consent, making sure the client understands with this therapy, with this surgery, with this medication, there are risk factors. Okay. Yes, the benefits are there, but there's going to be some risk. There could be some very serious side effects. There could be some serious adverse effects. Adverse effects, they can occur, but we don't expect them to occur, but we are prepared for it anyway. Your client will need to sign informed consent with radioactive iodine. The goal is to destroy thyroid cells. Okay. Now remember, this is only if the regular typical medication, the anti-thyroid medication just do not work. Then we go to the iodine. Okay. Now, the concern is that are we going to damage so many thyroid cells that we now have what condition? So this is critical thinking. If we destroy too many thyroid cells, what could I send my client into? What's the risk?
Hypothyroidism.
Hypothyroidism. Exactly. Yes. iPhone. Whoever's joining from their iPhone. Yes. Oh my. I hope I'm saying that correctly. Okay. Now, crises, we're actually going to talk about crises. Okay. But crises wouldn't happen with the iodine therapy. You're going to be destroying thyroid cells with the hope of calming down the stimulation. But again, there's no exact science to doing this. So it's not like I can control how many thyroid cells get destroyed. Okay. So this is a very calculated treatment for hyperthyroidism. Okay. Now, worst case scenario, the typical anti-thyroid medications don't work. The radioactive iodine do not work. There is another option, surgery. Okay. Now, surgery is going to work. Okay. If the doctor or if the client is just not comfortable with radioactive iodine, honestly, a lot of clients are not comfortable because of the risk factors. So, surgery is typically a safer option, but it's still surgery at the end of the day. And there are still risks involved with surgery. Okay. So, again, an informed consent will need to be on file. Okay. So, with surgery, you're going to take a portion of the thyroid. That's it. Nothing more complicated than that. The goal, if I take some of this thyroid, hopefully all of this overstimulation will kind of get knocked down a little bit because there's not as much thyroid there to do all of that producing. Now, critical thinking. Okay. And I did put it here. And I should have left it off, but I wasn't thinking what gland sits on the thyroid and is there. But if you just don't look off the top of your head, and this is basic anatomy and physiology, what other gland sits on the thyroid? The parathyroid, exactly. Now, my next question. What is the parathyroid responsible for, or what is one of the main functionings for your parathyroid gland? I expect
Produce
my
calcium.
to regulate calcium
Calcium.
levels in your body. Yes,
Cash.
exactly. Okay, so that is something as nurses we need to know. Nobody is going to tell us that. The NCLEX wants to know that you understand if you
Your
and
imagination.
it's called a thyroidectomy. Okay, if the client has a thyroidectomy performed, what do I need to monitor? I need to monitor electrolyte calcium because the parathyroid gland sits on the thyroid gland itself. So if you cut a portion of the thyroid out, you can also inadvertently cut out a parathyroid. The parathyroid monitors calcium levels in your body. If your body has too little calcium, it is going to stimulate the pituitary gland. It's going to stimulate what we call parathyroid hormone. And that is going to directly increase calcium levels in your body. Okay. And it does it through bone breakdown or the osteoblast cells. That's going way mid surge. Okay. Now, of course, if there's too much calcium in your body, then the pituitary gland says, okay, I don't need to produce parathyroid hormone. Levels are too high. Hopefully, the levels will kind of taper off on their own. Now, critical thinking, this is a big one. When you have altered levels of calcium, okay, let's say low levels, what type of manifestation might I see? Like if I just had to monitor my client because they have their electrolyte calcium is not the level where it should be, what are some possible side effects that I might see? Chavoski sign. Okay. There. Oh, look at
Certainly.
Trousseau. Yes. Now on the flip, yeah, look at you. Now here I go thinking y'all wouldn't go know this. Of course y'all would know this. Exactly. Again, this is something that the NCLEX wants you to know. Listen, however you gonna remember it, that's how you remember it. However, if you gotta spell it a funny way, if you gotta put it into an acronym, short whatever it takes, that's how you learn it, that's how you remember it. But that's exactly what you need to monitor for. So I would need to monitor labs if I have a client that has a thyroidectomy. I need to monitor not just because of the thyroid hormone. Now I have to monitor my electrolytes because of calcium. Okay, those are the types of things you need to know for the NCLEX. That's called critical thinking. And again, no doctor is going to call you and say, "Hey, nurse, remember now, the client had part of their thyroid taken out. Remember, parathyroid sits on the thyroid. So I took out one of the parathyroids. So you know you need to watch the calcium." Nobody's going to tell you that. That is something that you as the nurse would need to know. Okay. Thyroid storm. Will said, I have not. Listen, we gonna get there. I got a little slap of that too. I got you. I got you on that. Don't worry, we gonna get to that. Look at y'all thinking ahead. Okay. And also keep in mind, if you treat hyperthyroidism, your client can go into hypothyroidism. So not only do you need to know the signs that shows your client's condition is improving, meaning if I treat hypothyroidism with levothyroxine, how do I evaluate if it is, working? That means the signs and symptoms of hypothyroidism will start to go away. On the flip side, how do I know the options for treating hyperthyroidism is working? The hyperthyroidism signs and symptoms start to go away. And now we're starting to have, equilibrium in the body functioning.
Dieting too is good.
Say it again.
Say dieting also.
Oh, when we get to the nursing management, lifestyle modifications, exactly. That exactly goes with that. So, nursing management, hypothyroidism. So, as the nurse with a client with hypothyroidism, I need to assess your appetite. I need to monitor your weight. Remember, with hypothyroidism, weight gain is effortless, even if you're not trying. Okay. When we say monitor bowel functioning, the client is constipated a lot. So now we're talking about possible GI disturbances. Okay. And because the skin gets very, very dry, the skin can get cracked, the skin can bleed. I'm going to also need to give my client very good skincare. Okay. Education, always important when a client has hypothyroidism. Okay, making sure the client understands medication, levothyroxine. This is a very serious medication. You have a very serious condition. You need to be compliant with the orders. Okay, if we tell you take this first thing in the morning on an empty stomach for best absorption, you need to take it first thing in the morning, empty stomach, best absorption. Again, it causes insomnia. And we want to make sure that it mimics typical hormone regulation and release. So taking it first thing in the morning is the best thing to do. Lifelong, and it is lifelong. Exactly. A lot of people think, oh, if I take it for 6 months, I'm gonna be good, or I don't. Nope. Lifelong. Okay. Also, you want to teach them how to manage their own complications, side effects. If you have a client that is constipated, very simple. Okay. Now, this is also where students get things confused. We're not going to always give a person a laxative. The laxative is a stimulant. Sometimes people do not need a stimulant, they just need help going. So, stool softeners, okay, you need to make sure you stay hydrated. Not only because your skin gets really, really dry, but because you suffer from constipation, you need a lot of fluid in your diet. You need a lot of fiber and green leafy vegetables. Yes, fluids, fiber, green leafy vegetables, that needs to be a staple in your diet because of your always, always, always risk for constipation. Okay, yes, high fiber to help the client go. Okay, moisturizers for dry skin. Now, once the treatment of hypothyroidism gets into the body and you're at a great level, you will no longer have to do all of this. So, we're teaching you how to manage your side effects, your symptoms, until your body and your hormones start regulating itself out and you see less constipation and your skin becomes more moisturized. So, this is not something you have to do. Fiber with water, drink a lot of water. Okay, a lot of water. You have to stay hydrated with hypothyroidism. Okay. Now, follow ups. Again, you're going to have to come in however often to get your thyroid levothyroxine levels drawn. We need to make sure you have a therapeutic range. and the levels are not too high, because that means the doctor will need to adjust. Now, as the nurse, we do not have the authority to adjust anybody dosages. It's always the healthcare provider, but we can look out for signs and symptoms that maybe could be an issue with the medication, and for the doctor to take a look at it. Okay. And again, with the levothyroxine therapy, empty stomach, same time each day, first thing in the morning. Do not mix with other medications. So if you take levothyroxine and another drug, kind of space it out, 2, 3, 4 hours apart, depending on the medication that you're taking. But the doctor will give you more of a specification of how they want you to take medications if you're taking more than one and you're taking levothyroxine. Next, you have nursing management for hyperthyroidism. So, vital signs. This is important. This is classic NCLEX material. Okay, somebody in the chat already mentioned it, something called thyroid storm. There is a separate slide. After the next break, we'll talk about thyroid storm. So there's a very serious life-threatening complication called thyroid storm. So this is when all of a sudden, very quickly, your thyroid just boom, all of a sudden it just explodes with overstimulation. Okay, you already have an overstimulated thyroid gland, but with thyroid storm, you'll have and just like your thyroid gland just goes into double time. Okay. One of the first things you're going to see, or somebody said in the chat, let me see. Vitals will be, yes. And I was just about to say, one of the first things you're going to notice, the client's temperature will spike like instantly. It is quick. So they go all the way to being febrile. And we're talking about 103, 104. We're not talking about, 101, 102. We're talking about fever, high fever, febrile. And once you reach about 103, you start having seizures. So you need to monitor increase SNS except GIT. I don't know if anybody knows what you mean, Miss Rachel. If you want to unmute and explain, maybe you can help somebody with that. High fever, yes, heart rate also increases as well. So your vitals are going to jump. Okay, you might even see some changes in the blood pressure. Okay, blood pressure will spike, heart rate can spike, and the fever will jump considerably. Okay, you may have some heart rate disturbances, some murmurs. The client may even start complaining of chest pain. Okay. Now we treat hyperthyroidism, thyroid storm, but I'll wait. I'll get into that because I have a separate slide for that. For managing hyperthyroidism, they may need some oxygen as well, especially if they are complaining of chest pain and their O2 stats are dropping on room air. Okay, we want to make sure clients understand treatment for hyperthyroidism. Remember, anti-thyroid drugs, radioactive iodine, which will need an informed consent, thyroidectomy surgery, which will also need an informed consent. Okay, and just make sure also, they may need to be put on oxygen if they're starting to have respiratory difficulties. So in hypo, we have low fever. Yes, typically intolerance to cold. They could be a little hypothermic. Absolutely, yes. Okay. And then of course, cooling blankets. The goal is to get your temp down as soon as possible, as quickly when a client, and this is really for the thyroid storm, because when the temp starts to climb, that is one of the first manifestations. This is starting to happen. So we do measures to get your fever down. We gonna give you the medication, but we want to give you a little bit of help. So we may use cooling blankets as well to kind of bring that temp down as quickly as possible. Okay, and we talked about thyroidectomy. Now keep in mind, depending on how much thyroid they cut out, your client will become hypothyroidism. So they didn't went from hyper to an overstimulated hormone to a very understimulated hormone because they have cut so much. Sometimes they got to take the whole thyroid. It's not like they leave a piece behind. They got to take out the whole thyroid. So now you have no thyroid. There's no TSH level to stimulate. You're going to become hypothyroidism. Now you're going to have to take Synthroid as well. And again, this is lifelong. Okay. So it is 10:20. Let's take our next breather. 10:30, we'll come back and we will finish Hashimoto's, we'll finish Graves' disease, and we'll go through thyroid storm. Those are very, very quick. And then we'll jump right into our NCLEX questions. So 10:20, we'll be back at 10:30. So we was on a break. I see you saying hello to everyone. Okay, you guys. So we will finish out Hashimoto's thyroiditis. We'll finish out Graves' disease. We will finish thyroid storm, and then we'll jump right into our NCLEX questions. Okay, so I have one little slide for each of these conditions, just kind of building up on what we've already discussed. So first up is Hashimoto's thyroiditis. Okay, so this is the number one cause for hypothyroidism. So this is not a complication, this is a cause. So this is an autoimmune condition. Okay, now this condition and hypothyroidism are similar, but there are still some differences. Okay, hypothyroidism is just an underactive thyroid. With Hashimoto's disease itself, okay, this condition is autoimmune. The body causes the attack to the thyroid gland, and then that is what causes the underproduction. Okay, so Hashimoto's thyroiditis is like a precursor to hypothyroidism. Okay, you have your typical signs and symptoms that you're going to start seeing with hypothyroidism: weight gain, decreased appetite. And that's another thing. I don't know if I mentioned it. When it comes to nutritional intake, we also have to be on top of the clients because they're going to have a decreased appetite. So you already having issues with constipation. Now your appetite is not the greatest. We need to put these clients on like a regular scheduled diet. You know, they don't have to eat. It's the same as no, Cushing's is actually Cushing's we're going to discuss next Wednesday. Okay. Cushing's is the adrenal glands. So these are totally different. You might see some similar signs and symptoms, but Cushing's is the adrenal gland. So we'll go over that. That's actually next Wednesday. Cushing's and Addison's and that's next week. Okay. Um so you're going to see, like I said, some of the same manifestations of hypothyroidism, but remember, this is the cause of hypothyroidism. There's other things that can cause hypothyroidism, but this is one of the number one ways, and it is kind of managed similar. Okay, thyroid replacing hormone, levothyroxine, and a lot of emphasis on lifestyle modification. Okay. Diet. There's a such thing as an anti-inflammatory diet, believe it or not. One of the main scientific reasons to believe why the body all of a sudden starts attacking itself is because of inflammation. Okay. Now, again, we don't know why the body all of a sudden attacks itself, but science kind of gives us insight as to some things that we might expect to see. So we do put the client on something called an anti-inflammatory diet. And that is, of course, you're going to eat foods that are less likely to cause inflammation. So, for example, okay, gluten. Gluten is not your friend if you have a lot of inflammation. Okay, so gluten-free diet. Okay, a lot of whole grains, a lot of vegetables, a lot of fruit. You know, sometimes red meats can cause inflammation. You know, so things like that is kind of sort of where they're headed when it comes to an anti-inflammatory diet. Healthy fats. There's a such thing as healthy fats. Olive oil is a healthy fat. Avocados, healthy fats. Okay, so no trans fat, less of that. Artificial dyes, artificial colors. So basically, a lot of clean eating. That's another good way to put it. Okay. Then you have what is called Graves' disease. Now, Graves' disease is one of the number one causes for hyperthyroidism. This is also an autoimmune condition. So again, all of a sudden the body starts to attack itself. But with this particular type of autoimmune disorder, this causes an overproduction or overstimulation of the thyroid gland. Okay, you're going to pretty much see the same signs and symptoms. Okay, but there is a couple of things that are added to it, and I do have pictures because it helps to visualize. So we do the same medications: anti-thyroid medications, radioactive iodine, surgery. Okay. Now, when we talk about manifestations, okay, in addition to the common things you see with hyperthyroidism, there is something else you're going to see sometimes with Graves' disease. And these are your clinical manifestations for Graves. So when I was talking about the goiter, that's the first picture. Okay, this is what a swollen, enlarged thyroid gland will give off in terms of signs and symptoms. This big swollen area of the neck, okay, that is called a goiter. And this is commonly seen with hyperthyroidism. And again, it is a swollen thyroid gland. Okay, the second picture is the classic manifestation also for grave disease, and this is called exophthalmos. Let me see. Yes, the bulging eyes. Okay. Now, this could be problematic because what happens is the eyelids kind of retreat and the tissue swelling behind the eyes causes the eyes to push outwards. That is where that look comes from. Okay, so your eyes are pretty much the same size. It's not like the eyes themselves get bigger. It's just that you have a retreat of the eyelids and the swelling tissue kind of pushes the eyes outward, and that's where that bulging look comes from. So if you have the goiter and you have ophthalmos, those are manifestations of grave disease along with the other manifestations of hyperthyroidism you would expect to see. So when your doctor is doing that, feeling around, they're feeling to see if your thyroid gland is starting to enlarge. Okay. And then lastly, you have a condition called thyroid storm. Now, thyroid storm is a potentially life-threatening condition of hyperthyroidism. It is rare, but we do still look out for it. Okay. Typically, what happens is all of a sudden, the thyroid gland just out of the blue is already, like I said, it's already overactive. But like now, all of a sudden, it's like a burst of being overactive, and it's all of a sudden it's going to release a bunch of thyroid hormones, and then all of a sudden you have a massive increase in your metabolism, and that massive jump in your metabolism, high fever, very high tachycardia. Then you start seeing the neuroscience, confusion, delirium. Some clients altered levels of consciousness. You start to see the GI symptoms, vomiting, diarrhea. And if it is not caught and managed quickly, the client will start to go into organ failure. Let me see in the chat. No. Oh, that's a good question. Will this happen if they cut off? This could be a reason to cut off the thyroid. Now, remember, when they cut off the thyroid, you're going to see hypothyroidism. This is a manifestation of hyperthyroidism. So this is seen with a overactive thyroid. So if they cut out a part of the thyroid, that would be to possibly treat this condition. But if they do cut the thyroid out, then you won't see thyroid storm. So this is only like a complication of having hyperthyroidism. Okay. It can be triggered by a bunch of different things. Infection is a big one. So just like, sickle cell disease, we tell clients, listen, try to prevent infection, wash your hands. We teach clients with hyperthyroidism the same thing. You are at risk for a condition called thyroid storm. It is life-threatening. One of the things that can trigger it is infection. Make sure you wash your hands, okay? If you feel yourself spiking a temp, you need to come in ASAP. We need to start treating you as soon as possible, okay? Getting pregnant and you already have hyperthyroidism can trigger a thyroid storm. Certain medications can trigger a thyroid storm. So we just try to teach clients, okay, to just watch and monitor their signs and symptoms. And if they start feeling, their heart beating faster, if they start spiking the temp, you need to come in ASAP. Okay. Some clients may even start having psychosis, hallucinations, auditory hallucinations, visual hallucinations. So that is why the education is so important, because as soon as you start feeling, some signs and symptoms, something is not right, come in ASAP so we can catch it early. Okay. Sometimes we may add beta blockers to the client's treatment. Now, they're already getting treated with the typical medications to manage hyperthyroidism, anti-thyroid hormones, medication. Let me see in the chat. Perfect. Anti-thyroid
So
hormones. Go ahead.
I was just saying, like, for the confusion and delirium, is that because of the thyroid gland because it produces like the heart rate, brain, and mood?
Because of metabolism. So what it is, your body goes into a Yes, to manage the tachycardia, exactly. So what happens is your body goes into a very hyper metabolic like state. Like your
Mhm.
metabolism is on like steroids, if that makes sense. And when that happens, that triggers all of the other responses that you're going to see. It's your metabolic processes. It just explodes. So all of the tachycardia, the high fever, the delirium, the altered levels of consciousness, the confusion, the GI upset, all of that is due to this super metabolic state that your body goes into with this sudden triggering of all of this release of thyroid hormones. So that's where all of that comes from, this hyper metabolic state that your body goes into. Okay, so other medications you may see added beta blockers, and as somebody said in the chat, this is to treat the tachycardia. So not only are we working to treat, so a lot of the symptoms are symptomatic, So in addition to the anti-thyroid hormones and all that other stuff, we're going to give you a cooling blanket because we need to bring your temp down quickly. We may give you a beta blocker because we need to bring your heart rate down quickly. Okay, if we need to manage the psychosis and the delirium, we're going to treat that. You might, see a lot of medication cocktail for these clients that goes into thyroid storm. Okay. And then with prompt recognition and treatment, you can recover from a thyroid storm. Prompt recognition and treatment. But again, if it is not caught in time, the client can go into organ failure. And for a lot of clients, there is no reversing this organ failure because the organs become way too damaged. Okay. So in most cases, if this is not caught quickly and treated effectively, this can be fatal. So the prognosis can be poor. Okay. So don't forget, yes, you have hypo and hyperthyroidism, but you also have the causes, Hashimoto's, Graves' disease, and then you have the very severe complication of thyroid storm. Okay. So that is the end of our do we need consent before we give? Yes, for the radioactive iodine, you absolutely do. Absolutely. Remember, the outcome is to destroy thyroid cells. So what if it just works too good? And when I say it works too good, for oral iodine, so the oral iodine might not be as effective. Agranulocytosis, yes, which is why you need to monitor the labs. That is why we tell clients when you're on these medications, you have to come regularly for your labs because these medications can be toxic. Absolutely. For the oral iodine, it totally depends on the severity of the hyperthyroidism, because sometimes the oral is just not enough. It doesn't work quickly enough. So that's why they do the radioactive.
Is there a
Okay.
precaution?
I mean, there's always a precaution with too much iodine, especially if you're allergic to it. So one of the things you probably have to be tested for allergies. Outside of that, I don't think there's any like great complication risk for just oral iodine. It is the radioactive that you would need informed consent for. Oh, let me see in the chat. In the chat, hi. Da, 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 da. Perfect. Okay, so let me share my screen again. We're going to get into these NCLEX questions. Give me 1 second. Let me exit out of this. Okay, so I picked some good questions this time because listen, y'all be answering my questions way too good sometimes. So I said, let me see if I can get some tricky ones for these my students this evening. So perfect. Here we go. You guys should be able to see my screen. Part two, NCLEX questions. Oh, you smiling? We'll see. Like, cause we'll see. Cause either I'm just that good of a teacher, or y'all is just way too smart for me. Because I'm like, how did they get that so quick? I thought I was gonna trick them with this one. That's what I be saying to myself when I be picking these questions. So, question number one. Instruct the client to take more fluid to prevent. Listen, why y'all see? That's nothing. Y'all so fast. You are absolutely correct. Now don't spoil it now. Look at you. Oh, y'all so fast. So question number one. So I started out nice for y'all. I'm starting nice. A client is being evaluated for hypothyroidism. During assessment, the nurse should stay alert for what? You always need to know your signs and symptoms. Okay. That's NCLEX for a lot of conditions. Just being able to recognize screening. Okay,
D is the answer. Decreased body temperature and cold intolerance.
D.
D, okay. I see a lot of D's. I believe I see a C. D's, and a lot of one C. So let's see. The correct answer is yes, D. Okay. So let's go back. I like to look at the actual questions and answers discuss them. So A is hyperthyroidism. Okay. We just talked about the bulging eyes. B is also hyperthyroidism.
Hyperthyroidism.
Okay. Keep in mind the signs and symptoms are opposite of each other. So if that helps you, if you just don't know which one is which, just think they're opposite. Okay. C, now that is not clinical or typical, but C is also a sign for hyperthyroidism. So decreased body temp and cold intolerance. Remember what I said in the beginning? When I have a person that's always cold, first thing I ask them, how's your iron? If their iron is fine, they're not anemic, how's your thyroid? Because again, intolerance to cold is a hidden culprit for hypothyroidism. Okay. Question number 2. The nurse is admitting a client diagnosed with hyperthyroidism. When laboratory results should the nurse expect? So select all that apply. If I were waiting on the labs of a client suspected with hyperthyroidism, what labs would I expect to see? So the NCLEX not only wants to know, do you know manifestations, but do you know your labs? Because labs are important to know.
BCD.
D.
B, C, D,
BCD.
E. E.
B, E,
Increase
B
T
and F.
increase TSH, increase T3, T4.
Yeah.
Okay,
A.
look at y'all. I B E F,
Um,
B C D.
decrease TSH level, elevated T3 level, and elevated T4
B.
level.
C.
Perfect.
Oh.
B C D. Perfect, perfect, perfect. I see D E F. Let's go back. So B C D, remember, decrease thyroid stimulating hormone. So decrease TSH levels because the pituitary gland is not stimulated to release. So there's decreased levels of TSH. And because your thyroid is overly stimulated, you're going to have high levels of T3 and T4. And again, that is the classic definitive way that we diagnose our thyroid dysfunction. I think I saw BEF. So you was right about B, but decreased T3, decreased T4, that is seen with hypo.
Hypo.
So hypo is the opposite. Hypo would be increased TSH levels and decreased T3, T4 levels. Okay, so they are literally opposites of each other. Okay. And this, of course, is the official lab value. But again, you just know the basics. Decreased TSH, high T3, T4. Question number 3. Which finding should a nurse expect to assess in a client with Hashimoto's thyroiditis? So now we're talking about Hashimoto's thyroiditis. Remember, it is similar to
C.
one of our thyroid dysfunctions, but it is not exactly the same. So I
C.
see a lot of C's.
Again. Mm-hmm.
These, okay? Again, keep in mind if you just,
E.
I can't remember. Remember, this
E.
is what brings about hypothyroidism. So I would
Yes.
expect to see a lot of the same
C.
similar manifestations, and that is C.
Yeah.
Okay, autoimmune disorder responsible main cause for hypothyroidism. Main cause for hypothyroidism
Weight gain.
because the body will attack the thyroid gland.
Mm-hmm.
Okay, perfect. Look at y'all. Okay, we'll see. I said I'm gonna start nice. I said I'm gonna start nice and then I'm gonna work up. But okay, y'all on top of it today, as usual. Question number 4. A client has been diagnosed with hypothyroidism. Which statement by the client will demonstrate appropriate teaching by the nurse? So this is a type of question where you are assessing if teaching is effective or ineffective. So if teaching is effective, that means the statement is accurate.
Let's see.
Okay.
B.
They have to increase their
Oh,
fluid intake.
Then
I
as
heard.
hyper for fiber and fluid. The B is caloric, high protein and high caloric.
Well,
C,
look.
because
Oh, wait. I just saw in the
C.
chat, Miss Crespo. I missed it. I want to make sure I get you. You put why not A. Is that for the previous question? Nicole Crespo. When you said why not A for the previous, okay, I'm going to go
Oh,
back. You guys sit
sorry.
on number 4 for a little while. I
You
missed it.
wrong.
Listen, if I miss your chat, just you can unmute, say, Professor, I asked you something in the chat. Please stop me. I just happen to catch it. So Miss Crespo wants to know why not A, which is a great question. Okay. So with hypothyroidism,
Yes.
okay, is hyperdefecation. That is the same thing as saying diarrhea. That's like a fancy way for saying diarrhea. Hyperdefecation, diarrhea. Remember, with Hashimoto's, which causes hypothyroidism, you see a lot of constipation. Okay. And also, so that's kind of what threw it off. Now, remember, with questions like this, that's why it's important for you to read everything. Because with questions like this, they could include, one thing that is also the weight loss. Weight loss is another one. Okay. Remember what I said, when you have hypothyroidism, a lot of times you have trouble losing weight. It's like you
Yes.
gain weight very easily. So you wouldn't see weight loss either with hypothyroidism. You see weight gain. Okay. So those are more specific for hyperthyroidism. Okay. Yes, Hashimoto's is weight. Again, somebody put in the chat, everything slows down. That's exactly how you would look at it. So for this one, I saw a lot of C's. The correct answer is C. Okay, let's go back. Remember, one of the main manifestations is constipation. Okay, so we need to teach the client proper diet. You want foods that are high in fiber. You want to stay very, very hydrated. Drink a lot of water. Eat a lot of high fiber foods because of the constipation. Okay. A doesn't really have anything to do with managing the condition of hyperthyroidism. And A could just be a support group, but that's not, really directly relevant. B, caloric intake, that
Hi.
doesn't also really do anything for hypothyroidism. Yes, Julia.
Mhm.
It looked like somebody was about to say something.
No, I say B is for hyper.
Yeah. Because with a person with You know what? This is why I can't put my phone when I talk. Siri thinks I'm talking to it, so Siri will answer me. But yes, when a person has hyperthyroidism and they burn a lot of calories, that's why they can't gain no weight. They can just eat, and it's like I lose weight effortlessly. So they would need a high calorie diet to support, because remember, they have a higher metabolism, which is the precursor for thyroid storm. Their metabolism just jumps super, super high. But they do have a very high metabolism to begin with. That's why they lose weight loss very effortlessly. So yes, see, fiber and fluids, make sure you stay hydrated and make sure you eat a lot of fiber. There's fruits that are very, very high fiber, vegetables, very, very high fiber. Worst case scenario, we'll also, give you some stool softeners, and those are over the counter as well. Colace is probably one of the number one stool softeners you'll see being prescribed. Question number 5.
Professor, I'm
Yes.
sorry. I'd like to ask a question with regards to question number 4.
Okay. Let me
So
go
I
back.
know that with a patient um, that has hypothyroidism,
hmm
they do retain fluid, right?
They can, yes. That could be part of their weight gain. Yes.
Okay, so shouldn't the fluids be monitored?
Not necessarily. So they're not gaining weight in that sense. They may
Okay,
have some swelling, puffiness, but it's not like when you think of weight gain, fluid retention. It's not like how you would see like a heart failure. So it's not
okay,
it's not like that.
okay,
Um it's more or less they may just have a little bit of puffiness, but the weight gain is not that significant. And plus it's you and if by chance they do have that level of fluid retention, then you may see a diuretic thrown in, but that has to be a severe complication. It is the constipation and the dry skin, the dry mucous membranes, that will be more of a concern. So that would warrant fluid. But no, it's not like heart failure, that type of fluid, and no, not that type of fluid gain.
all right, thank you.
You're welcome. That was a good question too. So question number 5, for a client with Graves' disease, which nursing intervention promotes comfort? So comfort and care, one of your NCLEX client categories. So that means I need to understand what Graves' disease
D
is. I
is the
need to
answer. D.
That's, yeah, blanket,
B,
extra
giving extra
blanket.
blanket.
Yep.
I see D, I see B.
B.
B. B. Oh, a lot of B's. Okay,
D.
you guys are back and forth with this one. It's like DB, DB. I knew I was gonna get you with one of these questions.
They have the
Cooling blanket.
I knew I was gonna finally get y'all. So listen, you guys are literally back and forth, D and B. So let's think about it before I get to the answer. So we said Graves'
They
disease is
sweat a
the number
lot.
one cause of hyperthyroidism. So one of the manifestations of hyperthyroidism, one of the manifestations is heat intolerance. So for hyperthyroidism, these clients are hot all the time. So the correct answer is D. D, 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 D.
Yeah, she got
Let's
it.
D. Let's because I saw a lot of B's. I think I saw a C in there, but it was a lot of D's and a lot of B's. So let's talk about it. Okay. So for A, we would not restrict fluids. Okay. Restricting of fluids, again, they lose a lot of weight. They have very high metabolism. Restricting fluids is not going to cause comfort. As a matter of fact, because their metabolism is so high, we want to, they can just do regular fluid intakes. You don't have to, stop them from drinking fluids. Just like with hypo, they could just regular fluid intake just be adequate. Okay, just to stay hydrated. Extra blankets might make them hot. Remember, they already have an intolerance to heat. They feel hot all the time, even in an area where they're not that hot, or the environment is not that hot. They're hot. So putting extra blankets, you could be promoting, the heat retention that they have. Okay. Limiting intake of high carb foods, not high carbs. Carbs is not really a factor. They should be encouraged to have high calories, high carbs. Remember, they burn a lot of energy. Okay, carbs might help to support energy. Calories support energy, carbs support energy. Remember, their metabolism is very high. Okay, you know who else has high metabolism? People who it's almost like they're exercising a lot and they really not. Like the manifestations that they have, you would think like this person works out or they're in the middle of working out and they not. So those are kind of sort of the symptoms that you would expect to see, especially with the consistent weight loss or inability to gain weight. Let me see in the chat. B is for no. So somebody asks, is B for thyroid storm? No.
No.
With thyroid storm, their temp spikes very high, 103, 104, those numbers. So again, if I remember, Graves' disease and hyperthyroidism, they're kind of sort of the same thing. Graves' disease leads to hyperthyroidism. So it is still heat intolerance. So even with a thyroid storm, because of the hypermetabolic state, their temp goes up very, very high, very quickly. You will do the cooling blankets. So if
So
it
B
says
would be more
regular
for,
blankets, it needs to say cooling blankets.
so would be more for hypothyroidism then.
Yes, hypo. Now if it said cooling blankets, that is different. So if it doesn't say cooling, do not assume it's cooling. Okay, it has to say cooling. They burn a lot of weight. Exactly. They have a higher metabolic state. Absolutely. Yes. Okay, so that's why D is the answer, because they're always warm. You need to keep the temp a little low. Okay, low enough for everybody to be comfortable, but again, remember they have heat intolerance. Question number 6, so this is a good one. 2 weeks after a partial thyroidectomy, a client is being seen for the post-operative follow-up appointment. Which symptoms are screened for as an adverse reaction to the surgical procedure, select all that apply. So how do you critically think your way through this? Remember, what is the purpose of a thyroidectomy? What can happen if a client undergoes a thyroidectomy? And that is again why they definitely have to sign informed consent, because of the adverse reactions. This is not what we expect to happen, but it definitely can happen. So we want you to be aware that it can happen. Oh, it's taking y'all a while.
SCE.
It's taking y'all a while.
SCEF.
Ooh, I see some. I see DEF. I see DE. I heard ACEF. I think that's what I heard. ED.
Yes.
Okay, so it looks like a lot of
D and
D. Not everything. No, not everything.
EL.
Everything. I see CF. Okay, we kind of agreeing, kind of not agreeing. Okay, so let's see. Heat intolerance, hair loss, hyperactivity, dry skin, cold intolerance, and fatigue. So keep in mind, when you do a thyroidectomy, you are removing the thyroid. So if a client is hyperthyroidism, they can go into hypothyroidism. So those would be
EF,
B,
BDEF.
F. I saw a lot of DEF, so you was right about that, but a lot of you did not put B. Hair loss. Remember we said dry, brittle hair, that can break off, they can lead to hair loss. That is another culprit. When I was talking about women's health issues, okay, that is also something, that's why I said an underactive thyroid is a foundation for a lot of women health issues. Okay, that is why we first start looking at your hormones, all of them, to see what could possibly be causing the symptoms that this woman is experiencing, especially as you get older. So, heat loss, dry skin, cold intolerance, fatigue, those are all signs of hypothyroidism. So, remember, if you take out part of the thyroid, the client can become hypothyroidism. So, those signs and symptoms you will start to see. Okay. Oop, oop, oop. What about thyroid storm after they remove the thyroid? So again, with thyroid storm, I actually have a question about thyroid storm. So I'm gonna wait to answer that one. I don't want to give the answer away. So there is a question about thyroid storm. Question number 7. The nurse is teaching the client about levothyroxine. Which instructions should a nurse offer the client?
A. A.
A.
Of course, the answer is A. Not only should you take it on, oh, y'all quick with that one. Look at y'all. Let me see. A, all down the chat. Good job. Not only should they take it on an empty stomach, better absorption. Sometimes you're going to see questions on the NCLEX where the client is questioning, why do I have to do it this way? Why is what you need to also know the rationales. If a client asks you, why do I have to take this first thing in the morning? Because it is better absorbed on an empty stomach. It also makes you insomniac, meaning you may have trouble falling asleep. So by the time it's nighttime, we want the medication effect to wear off so you can go to sleep. And also, there's a possibility that it doesn't mimic normal hormone production, and we want it to mimic your natural hormone production. So in the morning, on an empty stomach, same time every day is the best way to teach. Okay? Where can we find the questions? So these, Miss Crespo, these are the questions that I chose and I created. So when you look at the previous recording, you can, I think you're able to download. So this you will be able to have in the recording. Okay.
Hello, Professor. Please, can you go back to the question? My network just
Which one?
misbehave. Question 7.
This one. So taking the drug with meals, that is incorrect because it may interfere with absorption. Taking the drug in the evening is incorrect because remember, it can cause insomnia. It can prevent you from falling asleep. And then so we don't like drug interactions. There's a possibility that levothyroxine can interact with other
My
drugs.
network was misbehaving when you.
So that's why we tell you to space it out. Okay, if you take other medications, take them like 2-3 hours, even 4 hours after you take your levothyroxine. Okay. Question number 8. The nurse is caring for a client diagnosed with Graves' disease. What is the nurse's priority intervention for this client? So, Graves' disease, precursor for hyperthyroidism. What should I prioritize for
Thank
this
you.
client?
B.
B.
B. I see,
Yes.
I hear B's, I
B.
see B, C, I see C. I see B's, I
What
see.
about promoting comfort?
Promoting comfort, yeah.
Now here's the thing. So let's talk about prioritization. Okay. A lot of students get
Priority,
tripped up
yeah.
because with
Temperature.
prioritization, keep in mind, you're not saying that these other options are not important. See, a lot of times people think with prioritization, because you pick an answer, you're saying the other answers are not important. They could all be important. Three could be important, two can be important, all of them. All the question is simply asking, what is the most important thing that I need to do first? Or what is the most important thing that I need to take care of first or watch for? Not saying I'm going to ignore the other stuff. So because we know what grave disease is, we know that it can lead to a very life-threatening event. The priority would be temperature
Temperature.
Right.
because of thyroid storm.
Yeah.
Okay. And that's what we also teach the client. When you go home, if you start to notice your temp is spiking, you need to come in ASAP because that could be thyroid storm happening. Okay. Now I'm going to go back to the answer option. Let me check the chat right quick. Nursing process, fever, sore throat. Yes. Assessment. The hypermetabolism state can cause organ failure. That is the ultimate thing we're trying to prevent. That is why we prioritize the high fever, because that is one of the starting signs, tachycardia, high fever, one of the starting signs for thyroid storm. The question could have said, assess the heart rate, assess the blood pressure. All three of those will spike with thyroid storm. So assessing vitals in general is a priority. The eye drops are also important. Remember, they have the condition, the eyes bulge. Sometimes they dry out very easily with that condition. So, yes, it is important to do the eye drops, but that does not take precedence over assessing temp. Stress could cause a high thyroid storm. We said there's a couple of things: infection, stress, comfort. Okay, it is important to provide comfort. Comfort could probably de-stress the client. So honestly, all four of these are things you would do for this client, but that's not what the question is asking. The question is asking, what is the first thing you need to take care of? So why not comfort? That is why
Infection.
comfort is important. Okay, but I need to worry about getting that temp together, and then I could start promoting comfort. Okay, it's not saying that the comfort is not important. Okay, because of priority, exactly. Because of the risk for thyroid storm, which is a life-threatening
Yes.
condition, you need to check the temp, you need to check the heart rate, you need to check the blood pressure. Everything else comes after that. Because what if the temperature is, not high? Okay, the temperature is good. Now I can probably put the eye drops in, and then I can start promoting comfort. Let me get this client
Yeah.
comfortable. Maybe the stress will drop
Reduce
a little bit.
stress.
Yeah, everything kind of comes after that. Okay. Question number 9. Which results? Oh, wait, I see in the chat. Let me see. Which results would indicate that levothyroxine sodium is effectively resolving the symptoms of a client with hypothyroidism? So another type of question you may see on the NCLEX is evaluation of interventions. It's not enough to know what to do. You also need to know how to evaluate. How do you know your interventions are
Hey,
working? What would I expect to see? So we know that
There'll
levothyroxine
be increased
hypo.
energy with loss. Yes. High temperature and pulse rate.
So a lot of A's, a lot of A's. So evaluating the effectiveness of
Yeah.
levothyroxine, I would expect to see A. Perfect. I'm going to go back so everybody can see. We know that fatigue is one of the general manifestations, so we expect their energy to go up. We know that these clients have trouble losing weight. They have a low metabolic state. So we expect them to start dropping weight. We know that they have an intolerance to cold. They're a little bit of hypothermia. So their core temp is going to increase. And they're also bradycardic. Remember, the opposite of hyperthyroidism. So the temp goes up, the heart rate goes up, they start dropping some weight, and they get a little more energy. Okay. Decreased edema. Remember, they don't retain that much fluids unless you start seeing organ failure. Okay. When you start seeing organ failure, like the kidneys might start failing, the heart starts failing, then you start to see more of a massive fluid retention. Okay. And we don't want the temperature to just stabilize. We want the temperature to increase. So it's little more than stabilize. Okay. Appetite. Yes, we want appetite to possibly improve a little bit better, but weight gain is not a part of improving. And of course, we want them to get sleep. So sleeping for your hours, that is a sign that it is not working because remember, levothyroxine can cause insomnia. So if the client tells me I'm too sleepy, I can't go to sleep, I can't go to sleep, doctor may need to adjust the levels a little bit. And we don't want the blood pressure to go up. We want the heart rate to go up. And we definitely don't want to lower oxygen saturation levels. We want the client to be able to breathe. So that is why A is the correct answer. And last but not least, a nurse is assessing a client after a thyroidectomy. The assessment reveals muscle twitching, tingling, along with numbness in the fingers, toes, and mouth area. The nurse should suspect which complication. So,
A.
and it looks like everybody on the same
That's
page.
tetany, yeah.
Yeah.
Tetany,
Yeah,
hemorrhage,
when it's
thyroid
switching,
storm,
yes.
laryngeal nerve damage. The answer, of course, is A,
Hypocalcemia, yeah.
because of the parathyroid gland. And a lot of people forget that. See, that's basic anatomy and physiology. The parathyroid glands sit right on your thyroid gland. So if you cut part of the thyroid out, you possibly removing one of the parathyroid glands, that is going to affect calcium serum levels. Okay. So when you have a part of your parathyroid removed, then you're going to see decreased levels of calcium.
Hypocalcemia,
And
yeah.
that's when you start to see the tetany. Okay. Again, with thyroid storm, that is going to help. And I think somebody asked me that, or somebody said that in the chat. Removing a portion of the thyroid is going to help thyroid storm because remember, with thyroid storm, you have an overactive, it's like all of a sudden at once you have an overactive thyroid. So if I need to quickly regulate your, then I might have to quickly take out a portion of your thyroid. Well, that's a last resort. We try to catch it early and we try to fix your symptoms and treat you. But sometimes it is life threatening and it gets that bad. You got to think, I need something to work quick. So, yes, removing part of the thyroid would help thyroid storm, not make the client go into thyroid storm. Okay. So before you guys go,
And you can also get like if you see frequent swallowing, that's not a good thing too.
You can remember, you have to think, what exactly does my parathyroid glands do? And that's just, that's basic fundamental knowledge going back, to your fundamentals, and you start talking about electrolyte imbalances and stuff like that. You guys should be able to download the PowerPoint. I'm going to type into the chat right quick. You guys see that link there? Please click on that link. Y'all know every webinar we post a link for feedback. Please click on the link and provide your feedback, what you guys think, anything you want to see more of, less of. Please, please, please click on that link. Now, quick question. For those of you who go back, you guys are welcome. You're welcome. For those of you who go back and look at the previous webinars for the PowerPoints, are you guys able to download them? I know when I upload them before the webinar, you should be able to see them and download them that way also.
Yes.
Okay. So for somebody in the chat who asked me about the webinar, you will be able to go back and see them and download them. Okay.
So apparently, Professor, hypothyroidism can be linked to Cushing syndrome and hyper can be linked to Addison disease, right?
So there could be a link.
Okay.
They're endocrine.
Yeah.
Okay, so everything is linked. Here's the thing, everything is linked to the pituitary gland. That's where everything starts from.
Okay.
So yes, there are connections. We're actually going to talk about that next week.
Hey, thank you.
Next Wednesday. So if you look, I don't know, I think I scheduled it. I believe I did Addison's, Cushing's, and I think I add diabetes insipidus
Okay,
as
that's
well.
right. Okay.
So yeah, so just have your questions next week. I already know. Just
Thank
be ready for next
you.
week.
I
Okay,
just
next
can't.
week. Yes, go ahead.
Yeah, whenever time I click on the link, it doesn't give me anything, and I just don't know how. So I always have to put my comment in the chat inside of the
So
page that
you're
I
you're
have.
saying the link that we post, it doesn't work for you?
Yes. No, it doesn't.
So there's someone from Naxlex in the chat. So she's saying that the link that is generated doesn't work when she clicks on it. Does anyone else have that issue? The link doesn't work? Because I think this is the first time someone has told me that the link doesn't work. I would say for you
Link for
to
the review.
yes, the review link. You're talking about the link that I post that tells you to leave your reviews?
Yes.
Okay, yeah, that's what she's talking about.
Oh no, it works for me. Yeah.
Okay, so
doesn't work.
some students says it works, some says it don't. It says doesn't work for.
Let me try.
Oh, okay. So you guys see the reply? It requires you to be logged into an active account.
My account is active though.
Okay, so she's saying her account is active. Should she
Hold
maybe
on.
contact IT
Let me
support?
let me click on it again and see if it will pull anything up. Hold on. Maybe I was doing it wrong. I'm not so sure.
Or maybe when you get out of the Zoom and you click on it, log into your account and click on it, maybe try that way.
Okay, I finally got it. Oh yeah.
Oh, see, that is. Okay. So
Okay.
whatever you did, everybody else needs. The people who
Simple.
saying it don't work.
I double click on it. I was just like clicking. There was a portion of it that was
Oh,
like a
got
copy.
you.
So I guess
Sometimes you have to like you double click or you kind of
yeah.
press control and click. That's what it is. Okay, I see what you're saying. Sometimes when you have links like that, it might ask you to press control and click at the same time or double click. Yeah. So sometimes, or you can always copy and paste it. Sometimes I do that when I have trouble clicking on links, I'll copy and paste it in my browser. If I already have the account open and I copy and click, it'll sometimes take me that way and also. So if you guys are having a problem, you can link up. I will send a message in customer support so it can go to IT.
I just
Mm.
clicked on it and I just did my, it went through for me. It was excellent. I didn't have any
Perfect. Okay,
problem.
now we
Yeah.
good. Perfect. Now the link is working. Awesome. Perfect. So are there any other questions? So next Wednesday, okay, we're following up the remaining for endocrine. So again, we'll be doing Cushing's, Addison's, and diabetes insipidus and symptoms of inappropriate anti-diuretic hormone. All of those are linked. Pituitary gland Yes. Okay. Miss Masha wants to know hypothyroidism code. Yes. So think of it this way: with hypothyroidism, you have a slowed down metabolic state. That's another way to look at it. So everything is slowed down. You have bradycardia, the blood pressure may be a little bit low, your body temperature is low. That could also contribute to the cold intolerance. So that means, let's say you are in a room and it's 75 degrees. Okay. In Miami, 75 degrees is perfect. Not too hot, not too cold. But if I have hypothyroidism, I can be in 75-degree weather, but to me, it feels like I'm in 60-degree weather or 50-degree, 40-degree weather. To me, it feels much, much, much colder than what it is. And that is because with my hypothyroidism, I have a very slow down metabolic state. Okay. So that's what it is. I am teaching on Sunday. Sunday is mental health. I can't remember exactly what Sunday's topics are, but yes, I do. I'm scheduled Sunday at 9. Yes. So that's what it is. That's why hyperthyroidism is the opposite. People with hyperthyroidism, they have a higher metabolic rate. So they're always hot. They sweating a lot. They always hot. So for these individuals, they would probably be in 75-degree weather but to them it feels like 100 degrees outside and it's only really 75. Okay, all it is the metabolic state. One state, the metabolic state is slower. The other one, the metabolic state is higher. Slower metabolic state, cold. Faster metabolic state, heat. That's all it is. You're welcome. Any other questions? I'm going to stop sharing for the time being so I can see the chat better. You're welcome, iPhone. I don't know who you are. Just say iPhone. You're welcome. You're welcome, Masha. You're welcome.
Thank you.
Okay, so yes, I am teaching on Sunday, so you can go ahead and register Sunday 9 to 11. I am there unless something comes up. I am already scheduled. Okay, and also I'll be scheduling more iPhone. I keep looking at iPhone person. I'll be scheduling more adult topics because so far I have until next week, but I should be getting more topics. We're trying to come up with more topics for the next set of webinars. So honestly, you guys, that's a great time to type into the comments if something that we haven't already covered in adult health. This is the time for you to add, you know what, I would like to see this covered, I would like to see that covered. So use the link for that because we're trying to come up with the next set of topics for the next round of adult health webinar. So this is your time to listen. I need to see this. This is your time to let your voice be heard because that's what we're doing right now. Eating disorders. Thank you. Listen, y'all know more better than I do. So anorexia, bulimia, I think, yeah, stuff like that. Go and register. So what that means is, wait, for the PDF. So once this loads, if you didn't get a chance to download, when you go back to previous webinars, when it's loaded, you'll have the opportunity to download. So when it says go and register, what do you mean? So you have to purchase an active account. Okay, so you have to register with the site you have to, they have packages for an account. So when you register an active account or you purchase a subscription, you can look at it that way, you'll have an active account. That's what that means. Yes, good luck to anybody that's testing. Good luck, good luck. Prioritization lecture. I would look into, so there's a tutor schedule that you can look into, and it tells you the topics for the next upcoming webinars. Prioritization, I don't know if that's who would cover that. That could be leadership if there's a leadership webinar. But if you don't see anything for prioritization, then you can put that into the link. You know, we would like some prioritization is very important. It is on the NCLEX. Definitely. And a lot of students do have issues with prioritization. So you know what? Put that into the comments. You know, like I said, now we're trying to put together the next set of, I could easily cover prioritization. I don't have a problem with it. So I will make that suggestion for the next set of webinar topics. Can we add prioritization? But remember, prioritization can be pediatrics, it could be maternity. It's just how to select what is most important. That goes across the board. Okay. Any other questions, ladies? And if there's any gentlemen still left, any other questions? You guys are welcome. You're so welcome. Yes, truly.
I'm just typing in. I was just typing in the review right now.
Okay, perfect. So like I said, you're welcome. You're welcome, Anne-Marie. So like I said, you guys use the link to voice your opinions. Again, what more do you want to see? If there's something that hasn't been covered, please, that's your time to say, we want to see this content covered. You know, whatever you need on it. Because listen, you don't know what's going to be on NCLEX. So if it's something that you kind of struggle with, if it's not just for me, if it's a maternity topic that you didn't see or you would like to see again, there's always the possibility to repeat something. That is perfectly okay. Sometimes you repeat stuff. Okay. Thank you, Anne-Marie. Thank you so much. So yes, you guys, please use that. Use that link to your advantage. This is when your voices get heard. Okay. And I'm also going to put together my own list for some things that I would like to cover also in adult health. Mental health is still going. Like I still have a couple of webinars still going into June for mental health. So mental health hasn't started over yet. It's just it's adult health we're starting to revise. Okay. Thank you, Anne-Marie. Thank you. So if there's no other questions, you guys, this will conclude tonight's webinar. I will see you guys Sunday. For those of you who join in Sunday, I believe it is eating disorders. But Sunday, also very, very important. It's definitely peds, women's health, it cross mental health. So it crosses a lot of content areas when you go over eating disorders. Okay, I will see you. Thank you. Get some rest, Anne-Marie. Yes, girl, because my
Thank you. Thank you. I always enjoy your lecture. Everything break down. It just stays in my head.
That's what my students tell me. When they test, they remember my voice. Good.
Yes.
Make sure you remember my voice when I tell you to do stuff. Perfect. Okay, kids, I will see you guys Sunday. Everybody have a great, safe night, and I'll see you guys later. Bye, you guys. Have a great night.
You too, Professor. Have a great night.
Bye.
Bye.